Okay, everyone, we're going to get started. Thank you all so much for coming today. My name is Trianna Lawson. I am an epidemiologist, and I also have the pleasure of serving as the U.S. coordinator and the wonderful moderator for today's presentation. Today, we will be presenting Dr. Pamela Payne Foster from the University of Alabama. She is a preventative medicine and public health physician who currently serves as a professor in the Community and Rural Department at the University of Alabama in Tuscaloosa, the School of Medicine as well. Campus, as well as Deputy Director of the Institute for Rural Health Research. Much of her work is centered in social health inequities through her close partnerships with community leaders and organizations. Dr. Foster's priority research interest is the study of HIV and AIDS related to stigma, particularly in faith-based settings in rural Alabama. Thank you so much, Dr. Foster, for coming today. You may begin.
Thank you so much. And it's so interesting. I was understanding a little bit about the Black August event, and some would say, why are we talking about HIV and STI, sexually transmitted infection prevention? But some years ago, the NAACP wanted to reframe the HIV epidemic as a social justice issue. So if we reframe it that way, and I'll talk a little bit about why they wanted to do that, you can really understand why HIV and sexually transmitted infections are still a major issue in our community. Next slide. So this is titled Updates on HIV and STI Prevention. Going back to that other slide, second slide. I just wanted to let you know what I'm going to talk about. Go back one more.
Okay, give me 1 second.
Just the agenda. What I thought I'd do first is kind of give you an overview of the HIV disparity in Black communities. That's why the NAACP named it a social justice issue. And I thought I'd give you updates on three new areas. One, believe it or not, vampire facials, and we'll talk a little bit about what that is. I'll also give a little overview on PrEP, and then I'll explain what that is as well. And then Doxy PEP is the third thing I'll talk about. So next slide. So HIV is, oh my goodness, so disparate among African Americans. In 2021, we accounted for 40% of new HIV diagnosis among people age 13 and older, although we only make up 12% of the population. And African Americans are much more likely to die from HIV infection than non-Hispanic white men. This disparity, as I stated before, the NAACP said, if we were to make Blacks in this country its own country, we would rank 16th in the world for HIV. So that's really sort of gives you a different perspective than these statistics here. Next slide. But the disparity is even greater in the Deep South. It used to be, of course, when the epidemic first hit in the 80s, it was, if you look at, this is a map just sort of showing the South, Deep South. But if you looked at a national map, initially when HIV started, it was in large cities on both the East Coast, New York City, and the West Coast, San Francisco. But now, going back to that Deep South slide, the South comprises 38% of the U.S. population, but represented over half of the new HIV diagnosis. The other thing that's of interest is the government now has a new initiative called Ending the HIV Epidemic. It's projected that we should be able to end the epidemic by 2030 based on the medicines, and I'll talk about PrEP as our primary prevention tool. But if you look at where the epidemic is still really hitting some of our subpopulations, the whole state of Alabama, for example, there are counties that are affected. So like I mentioned before, it used to be in large cities, but now it's in smaller rural areas as well. And there are priority counties, but a lot of the states in the Deep South are also priority, including the entire state. Think about Alabama. Alabama is primarily rural. We've got 57 counties. 57 of the 66 counties are rural, so still a major issue for some of these smaller areas. And I do research in stigma. A lot of what we know about HIV still is a lot of stigma involved, particularly in the Deep South. And we know the Deep South is also a place that is very religious. So that's why my research area is sort of focused on faith-based leaders. Next slide. So the CDC recommends that everyone between the ages of 13 and 64 get tested for HIV at least once as part of their routine health care. I talked about that stigma, but of course now what we're trying to do is normalize the fact that everyone should get an HIV test. Testing is really one of the important strategies for really reducing the epidemic, because a lot of people are walking around with HIV and they have no idea they have it, and that's the way it spreads. The other strategy for decreasing the epidemic is to, once a person gets tested and they get on treatment, they can bring their viral loads down so low to a fact that they can't even spread the disease anymore. So what we're trying to do as a national strategy is to get everyone tested, particularly those who are at risk, to make sure they get into care so they can get their medicines, treatment, and prevent the spread of the disease. There was a time when we saw that a lot of people were not able to bring their viral loads down because they were lost to care. They got tested, they might have gone into care for a little while, but they didn't stay in care. So that's really the strategy, as well as looking at some cluster outbreaks. People who with certain risk factors should get tested more frequently, such as 3 to 6 months. And of course, we know the risk factors are sexual activity without use of condoms, through sexual spread, and IV drug use is another one. We used to talk about spread from mother to child. That's pretty much gone away because we now pretty much treat all women who are pregnant. If we treat them for HIV, we can decrease the risk of transmission to the child. But of course, we know a lot of mothers do not get prenatal care and so get lost to care. So that's one issue. We used to also say that breast milk contained the virus, HIV, and that could be spread from mother to child. But if a mother is on HIV treatment, then she decreases that risk as well. So those are some advancements we have made. Next slide. So this is a report that came out in April of this year, and it was very interesting. MMWR, as Trianna knows, this is a morbidity and mortality weekly report that we in public health use to really talk about new issues that are, and public health issues that are out there. This was the title: Investigation of Presumptive HIV Transmission associated with receipt of platelet-rich plasma, microneedling facials at a spa among former spa clients. So this was new. We had never heard about HIV being transmitted this way. So next slide. So what is this long title, platelet-rich plasma, microneedling facial? It's what we call vampire facials. Go back for a minute. We all know this picture of Kim Kardashian. Go back one more. Just want to show her because it kind of shows the influence of Kim Kardashian. Yes, so we know this is Kim Kardashian, right? Picture on the left is her getting this procedure done. Lots of little micro needles being done. The idea is that you use your own plasma. What they do is spin it down and the blood down from a person. They get the plasma-rich, platelet-rich plasma, and inject it back into the person. On the left, you see those tiny little marks. And then on the right, it's supposed to really improve the skin. And she, we know she's very influential. She talked about it, and this is sort of what made it popular. Next slide. So again, they are facials where they use platelet-rich plasma, PRP, with microneedling. It's a simple, usually minimally invasive, non-surgical cosmetic procedure, usually performed by dermatologists and cosmetic surgeons at licensed facilities and medical spas. And it, like I said, it involves drawing blood from the client, separating the platelet-rich plasma with a centrifuge before injecting the plasma back into the face with tiny needles. And then that's accompanied by a acid filler, which may result in improved skin texture and tone and a more youthful appearance. So next slide. So these are some of the side effects, usually mild discomfort. Mild effects are generally minimal and temporary, and they may include all these symptoms: bleeding, swelling, mild bruising, redness, and tenderness. Next slide. And that's what you saw in that picture with Kim Kardashian on the left. But what happened was in the summer of 2018, and let me go back for a minute and say we did know that another way to get HIV transmission is through tattoos, using needles where people, not in a tattoo, usually in a tattoo parlor, there are sterile procedures used. But for example, in prisons, we know people that do tattooing. They use instruments that are not sterile, and that's a way to transmit HIV. And we also know IV drug use. You can use needles between persons who are HIV positive and pass it on to someone else. That's why programs like needle exchange, where you exchange a dirty needle for a clean needle, work because it stops that transmission. So we knew about those transmission routes, but this one was new. In 2018 in New Mexico, Department of Health, they were notified of a diagnosis of HIV in a woman with no known HIV risk factors, who reported exposure to needles from this vampire facials. They did an investigation of the spa she went to. Also, the CDC got involved, and they identified 4 former spa clients and 1 sexual partner of a spa client, all of whom received HIV infection during this 5-year time period between 2018 and 2023, despite low known reported behavioral risks associated that we knew of at the time associated with HIV acquisition. And then they also were able to do some sequencing to say that these were all related to the same HIV. The HIV strains were all similar. And so they were able to kind of see that it came from these cases. Next slide. So what happened? This is a major issue. There was found to be poor infection control practices at this spa. So they did an on-site inspection of the spa. It revealed multiple unsafe infection control practices, a centrifuge, heating dry bath, and a rack of unlabeled tubes containing blood were located on a kitchen counter. Unlabeled tubes of blood and medical injectables like Botox and lidocaine were stored in the kitchen refrigerator along with food. There were unwrapped syringes found in drawers, on counters, and discarded in regular trash cans. The steam sterilizer autoclave was not found on the premises. Procedure equipment was surface cleaned only using disinfecting spray and other wipes after each client visit, and disposable electric tips were cleaned by alcohol immersion and reused. So major infection control practices, poor infection control practices, which probably helped with the spread. Next slide. So this was, I found this in an article that came across my desk. I don't think a lot of people really know about this particular MMWR um, um, report. So I just wanted to really make people aware, and I gave this talk at the National Medical Association for the Black physicians to let them know that these are procedures that are going on, to remind them and others about practicing universal infection control procedures, and also to warn the public about really going to places where they're not licensed. And that's really the big take-home message. We know many people who go get procedures from unlicensed providers and medical spas. So that's what I really want to warn people about. I wanted to warn the physicians about these practices within our medical community, but also get them to understand that we need to advocate for better, tighter regulations around medical spa clinics. That vanity medicine is huge. Everybody's looking for a way to look better, lose weight, these other procedures like butt expansions and other surgical procedures done by non-licensed surgeons is dangerous and should be avoided. So that's really the take-home message. So next slide, I'm sure I'll get some questions about this. So the second part of the talk is about PrEP. We still don't have a vaccine to prevent HIV, and our best primary prevention tool is PrEP. So what is PrEP? Next slide. PrEP is a short term for what we call pre-exposure prophylaxis. So this is where a person can take a medicine that can help them prevent HIV, usually for people who are at a high risk of exposure through sex, or they might have a partner who's HIV positive and they're negative, or they might use injection drugs. So it's highly effective, 99% effective for those at risk of transmission from sex, and a little less for IV drug use. When it first came out, this came out in 2012, so it's been around for almost 10 years. You could take a pill daily to prevent HIV, but we now have injection PrEP, which can be taken every 2 months. So that helps with the compliance of taking a pill every day. And how it works is it prevents it blocks the virus from making copies of itself and spreading throughout the body after exposure. Next slide. So the key with PrEP is you must be HIV negative. So in order to get PrEP, you have to be tested regularly, every 3 months. There are also some risk to your kidney and other organ damage. So you have to do lab tests on that frequent basis every 3 to 6 months. But it is still, like I stated earlier, our only preventive primary prevention tool. So primary prevention, if you remember, or if you didn't know, is preventing disease before it happens. So that is, key for a disease like HIV. Another primary prevention tool is not to have sex or not to do IV drug use, but we know that's impossible behaviorally. So PrEP is a good way to really get us to ending the HIV epidemic. That's the good news. The bad news is that Blacks, men and women, and other people of color, Latinos, are not getting PrEP, are not really getting the uptake of PrEP. And there are lots of reasons why. I mean, one of them could be the way that the PrEP was advertised was mainly to white gay men. And so women were left out of the advertising, and men of color were left out. So This statistic in 2021, only 11% of Black individuals for whom PrEP was medically indicated were using it, compared with 21% of Hispanic individuals and 78% of white individuals. So poor uptake. Study done in Birmingham showed that 18% of Black men having sex with men access PrEP services compared to 50% of new HIV cases. So still a major issue for our community. And as you also see, the South lagged all regions in equitable PrEP use. That's why I highlighted Birmingham, Alabama. Next slide. So there's a lot we can do there. Of course, the costs can be daunting, and every state is different. Between $60 for generic pills and $2,000 for brand name drugs. You've seen some of these on TV, Truvada and Descovy, and that doesn't include lab tests. But there are ways to get around that. There are some discounted programs and clinics that will help with these costs, as well as the companies that make the drugs as well. But still, that's a barrier if you don't have insurance or have a way to pay for it. Next slide. So this is two articles I pulled up that kind of show ways to kind of address some of the barriers. And one paper talked about really assessing the PrEP inequity at pharmacies using pharmacy data to enumerate PrEP users by race and ethnicity, sex, and using the U.S. Census data from 2012 to 2021. And they reported, the authors reported annual race and ethnicity, sex, and region-specific rates of PrEP use, and came up with a score called a PNR, and that's a metrics of PrEP equity to assess trends. So that's a way for us to kind of see where some of the inequities occur. And then some clinics are doing online PrEP treatment known as teleprep, which really makes it easier for people to consult with a doctor, get their PrEP prescribed, and then they will even online, and they will even mail the medicine to them, and they can even do labs via mail as well. And so that makes it much more accessible. And that cuts down also on the stigma attached to some of these treatments. Next slide. And this, because I was at the National Medical Association, I wanted to give them a code for where to get resources for PrEP, so we could begin to increase PrEP use in the communities of color. So this is on the CDC website, and if anybody wants to scan that, they can. So I'll leave it up for a little bit. But you can also go on the CDC website to look for resources. Next slide. So the take-home messages with PrEP, all physicians, and I'm also including community members, should be aware of PrEP as an important prevention tool in HIV. I did a study with about 80 pastors in 3 states. I did it with one of my mentors, Amy Nunn, who works in Mississippi. So we looked at Alabama, Mississippi, and Arkansas. We asked those 80 Black pastors, have you ever heard of PrEP? Not one knew what PrEP was and had heard of it. So, and we know that it's important for our ministers, local pastors, to be informed so they can inform their congregations. So everybody really should be aware of PrEP as an important prevention tool in HIV, and then rolling out strategies and developing policies which address PrEP inequities and decrease barriers such as increased access and costs are needed to address the HIV epidemic. So next slide. I do want to mention before I get into this one about doxy-PEP. There is, as we mentioned, with pre-exposure prophylaxis means prevention. There is also post-exposure prophylaxis. We call that PEP, and that's what you see here with even with this doxy PEP. But there is a PEP for HIV, So if you know that you've been exposed within a 72-hour period, you can take a treatment that will help prevent you from getting HIV. I do want to kind of mention this story. Recently, I'm in a collective of HIV researchers here at UA. We're called ARCH. And one of the researchers told the story. She's been empowering women, those who've been recently incarcerated, about HIV prevention. She was sexually assaulted. She knew that, she wanted to make sure she was not exposed to HIV, so she wanted PEP. She had been educated, knew about PEP. She actually called the health department, the hospital, and another ASO here in Alabama, made several calls, and none of them, first of all, when she called the health department, they didn't even know what PEP was, so they couldn't help her. And the other two also could not help her because of cost and just length of time. So just want to also lift up that as a way to really prevent HIV, PEP, post-exposure prophylaxis. So this is also true for some of our STIs. STIs, of course, we used to call them sexually transmitted diseases. Now we talk about it on a continuum. So we say sexually transmitted infections with syphilis being one of our major ones. Syphilis, gonorrhea, and chlamydia, of course, being our major ones. These infections have increased in the United States, they disproportionately, of course, affect gay, bisexual, and other men who have sex with men, and transgender women. And in 3 large trials, what they did was gave 200 milligrams of doxycycline, which is an antibiotic. They were taken within 72 hours after sex had been shown, after sex, and that has been shown to reduce syphilis and chlamydia infections by greater than 70%, and gonococcal infections by approximately 50%. So going back, CDC, and this came also from another MMWR paper in June, so this is recent. So now the CDC recommends that men having sex with men and transgender women who have had a bacterial STI, specifically syphilis, chlamydia, or gonorrhea, diagnosed in the last 12 months within the last year, should receive counseling about doxy-PEP. So you could give this medicine after any sexual exposure to prevent these infections. And it's really a shared decision-making process with their provider. They recommend that providers offer persons in this group, any of these groups, a prescription. They give the person the prescription to be self-administered within 72 hours. So the person says, oh, I had sex, maybe I should take this doxycycline. They would go into their pharmacist and get it prescribed. So they have to really understand when they should use it. And this is for oral, vaginal, or anal sex. And its recommended dose is 200 milligrams of the doxycycline, and should not exceed a maximum dose of 200 milligrams every 24 hours. So this is also new, and it gives those in the community some access to prevention. So next slide. So the take-home message for this is it's a novel, it's new, ongoing, patient managed. Remember, the person has the prescription and they can use it when they deem necessary. It's a biomedical sexually transmitted infection prevention strategy for selected populations. When offered, it should be implemented in the context of a comprehensive sexual health approach, including risk reduction counseling, STI screening and treatment, recommended vaccination and linkage to HIV. So at the same time, HIV, PrEP, HIV care, and other services as appropriate. And persons who are prescribed doxy-PEP should undergo bacterial STI testing. And they said at anatomic sites of exposure. Remember I said oral, vaginal and anal at baseline and every 3 to 6 months thereafter. An ongoing need for doxypep should be assessed every 3 to 6 months as well. And screening should be performed for HIV negative MSM and transgender women according to current recommendations. And I think that's my last slide. And these are the references, of course. And I think that's my last slide. So I took, a short amount of time because I really wanted to open it up for question and answers. So I look forward to hearing from you in the audience.